Thanks for the kind invitation. I really look forward to this event, and I'm privileged to have the association with De Montfort University with David Morris, and we've worked together to discuss many issues as to how we can build and develop this link. A bit about myself. I'm a plastic surgeon. I do a lot of breast reconstructive work. In my NHS practice, it's reconstructive and asymmetry and deformities post-cancer and reconstruction. And in my private practice, predominantly cosmetic work, enhancing, reducing breasts, and also dealing with issues such as asymmetry. So there's a lot of interface within my own work as well, and to develop further relations is quite exciting. So the sort of patients requesting surgery under most plastic surgeons' care are those with small breasts or breasts that are perceived to be small but not necessarily too small. They just want an enhancement. Large breasts, of course, patients requesting reduction, droopy breasts, asymmetry, and post-mastectomy. I've been in plastic surgery now since 1989. That's when I started my training. And I've seen a phenomenal evolution in the way we do reconstructive procedures and the way our techniques have evolved. In the late 80s, it was almost, we were in the sort of infancy of techniques. For example, breast implants. Wasn't a clear-cut definition as to how large we make patients, what sort of implants we use. The number of implants that are available on the market were quite limited, and we became more innovative if the companies were not innovative. And I recall if the size of the implants were not large enough, then we put in 2 sets of implants on the same size, and things that we'd sort of do that would be unthinkable now, but they've sort of evolved. And a point that was made by a speaker earlier on is to the degree of acceptability within size fit is seen as acceptable. But from a medical point of view, that sort of acceptability will not be seen as adequate. The reconstruction that was perhaps done 7-8 years ago would be seen acceptable by, I quote, a responsible body of medical practitioners, would not be seen acceptable now, and that can actually lead to an issue. And therefore, we need to constantly strive and evolve our techniques, and I'll come to that later. Right, a bit of humility about the female breast. And I think the last sentence, it is actually a very, looking at things objectively, it is an organ with varied volume, width, height, projection, tissue density within any one woman. When we do breast reduction surgery, we find that some women with large BMIs have, more fatty tissue relative to breast tissue, and vice versa in women who have lower BMIs. The width of the breast, and I'll show you some photos, the breast effectively going into the axilla, the axillary tail that it's otherwise caused. That can have profound implications for reconstructive surgery and for the fitting of bras as well. Projection is very important, and the plane in which there's going to be projection. So all these issues need to be assessed. The composition, the shape, and the position on the chest wall. And this is assuming that somebody's got a normal chest. And it's not assuming that somebody's got a chest wall deformity, such as scoliosis, kyphoscoliosis, or pectus excavatum or carinatum. And then we've already talked about changes in physiology, the aging process, and it can make the unacceptability of someone being small and having a large breast relative to their frame, and vice versa, a small breast on a large woman. And it is, I think, again, with humility, a difficult organ to assess objectively. I hope I'm not going to disappoint you. I wasn't intending to show too many plastic surgery slides about my practice, although it was very tempting to do so. I thought I'd keep it more sort of educative and stay to the nitty-gritty of patients having breast surgery rather than promote my own private practice. So basically, the measurements that we take, and these are expected of any trainee who comes through plastic surgery and is going to be assessed by our examining board and on our own assessment. The first measurement that we expect, this is working. Anything coming up? Anyway, the first measurement that we take is from the nipple areolar complex to the suprasternal notch system. That's a standard measurement, and that gives us an assessment of the degree of breastosis. And there's another slide that shows what breastosis is. I think commonly known as the pencil test, where you put a pencil underneath the breast and see how the pencil is in relative terms to where the nipple is. And the average page 3 girl, if there is such a thing, the nipple is quite above the inframammary fold. Type 2 is where it's at the level of the fold. Type 3 where it's profoundly southward. And pseudotosis is where the lower part of the breast, the lower pole, is drooping more unnaturally. Then the next measurement that we take of breast height A and B, which is a shame really, is, can you see that? Yeah. So basically, the breast height A would be with calipers to show the distance, the height of the breast base, and breast height B would be the same measurement but with with a tape measure to take from the upper pole of the breast to the inframammary fold. And similarly, breast width again would be with calipers from where the breast starts medially and to as far laterally as possible with calipers. And you may find that someone who's slim, that distance may be similar to taking the same distance with the tape from the same point to the same point. So there's a variation in the two. And I'll come to the relevance of those. And then the pinch test. Now this is not as objective as we'd like it to be, and this is very relevant to when we're doing breast augmentation surgery. We take the calipers, and then at the middle and upper 1/3 of the breast, we pinch the breast tissue. Anything more than 2.5 centimeters or so, we'd be comfortable to put a breast implant underneath the breast tissue. But anything less than 2.5 centimeters, we think about going underneath the muscle to give proper coverage, assuming that the woman does want to look natural. If they want that sort of FHM look, without mentioning names, it actually becomes very easy for us. We don't need to take these measurements. We put in, whatever randomly sized implant that comes our way, and we give them that sort of look. So it actually goes against, conventional teaching. But anyway, so staying with the issue of ptosis, normal, grade 1, where the nipple areolar complex, depends on the definition, is at the level of the fold. Grade 2 is where it's somewhat below. Grade 3, where it's, as I say, southward. And pseudotosis is where the lower pole is more so. And to give you some examples, a lady who's lost about 6 or 7 stone in weight, significantly droopy breasts, and the pencil test, as is commonly known, will be fairly positive here with grade 3 ptosis. And this is a lady who has had a breast augmentation done, and in her case, as you can see, the implants are perhaps slightly wider and higher than what they should be, and therefore you can see the lower pole is more pronounced, and you can actually see the scar over there showing a degree of pseudotosis. Further measurements. This is a very important measurement, especially when we're doing breast reduction surgery. The nipple areolar complex to the inframammary fold. This distance is very important in planning the degree of breast reduction, the type of measures that we need to take, and also in patients having breast augmentation surgery, the type of implant that we should use, how much lower pole fullness should this person have. So we've got to look at the whole breast in terms of upper pole, middle, lateral, and lower pole as well. So we talked about breast base, and that's being breast base A and then B, but we're also looking at nipple areolar complex to the lateral edge of the breast, which would be from about here to there. And that's to show whether there's any deficiency in that aspect of the breast. And that can vary in distance on someone who's got asymmetry and has got an NAC to medial edge of breast. That would be different measurement in that person, although would be reasonable in a normal, in the average breast. We need to assess the chest wall as well, because patients can have pectus excavatum, which is basically where there's a significant dip at the sternal level and various gradations of that. pectus carinatum is where they've got a pigeon-type chest and the sort of the sternum is more prominent, and Poland syndrome, which is a syndrome where basically half of the chest associated with the arm can actually be reduced and hypoplastic, and it can affect breast growth as well. So when we're assessing the chest, and patients with Poland syndrome may actually have an absence of the muscle, both on the fractus pectoralis major may be absent, latissimus dorsi may be absent, and that can have profound implications to what sort of reconstructive procedure we do. So to give an example of someone who's got a chest asymmetry in the sort of examples, the relevance of these measurements. As you can see on the right side, she's got significant hyperplasia. The pinch test on the right was 1 centimeter. So basically, if any implant needs to be put on the right side, it would have to go underneath the muscle. The inferior pole, the distance from the inframammary fold to the nipple areolar complex, that on that side was only about 6 centimeters. So significant lower pole loss of tissue. The measurements from the nipple areolar complex to the medial edge and the nipple. By the way, am I without? Is my voice carrying? Yeah, fine. So if we're looking at nipple areolar complex to medial edge of the breast and lateral edge on the right side, that's adequate. And she doesn't have any ptosis on the right. But if one then gives some attention to the left side, you can see quite notably she's got grade 3 ptosis. The nipple areolar complex is at a significantly lower level than the inframammary fold. And markedly on this side is something that's actually very difficult to correct. The nipple areolar complex to the medial edge is quite larger. I don't think I have a lateral view on this one, but the distance from the nipple areolar complex to the lateral edge is actually quite shortened. It's constricted. So she's got, on the right side, she's got lack of fullness in all quadrants, but notably the inferior quadrant. And on the left side, ptosis plus lack of fullness on the lateral aspect. Can you see the sort of detail that we try to go into to achieve reconstruction, and how we can perhaps fit that in the assessment of bra fit? So this lady, she actually had a 2-stage procedure. On the left side, to have a mastopexy procedure, which is a uplift procedure, and on the right side to have a breast augmentation initially with an expander, a tissue expander, which basically we put the implant in, pump it up with some saline, build it up, then we get the appropriate size, and then we take that implant out and put in a new implant in. And in this case, she had an anatomical implant, because on the right side, she doesn't have shape, she doesn't have size, so she needed an anatomical shaped implant. And that's her after the operation. Overall happy with the results. Difficult to achieve much more in these circumstances with their limitations, how much we can do. Bit critical about myself. The nipple area complex to the lateral fold, still a bit short, but that's actually very difficult to correct. But further surgery can be done to deal with these issues. And that's the way we like to evolve our practice. If patients want to come back for revisional surgery, we try our best to do something or the other to improve things. She is young, long may she remain young, but she won't. And I suspect that over the years, she may come and her BMI may increase in size. She may want to have further surgery. Breast reconstruction, many ways of doing breast reconstruction. And this is, again, fascinating, the evolution of the techniques. The sort of techniques that we used to do in the early 90s would be seen as unacceptable nowadays. And this is the point that I made earlier, and the comparison, the sort of pressures that we have on ourselves. It actually can be, we can put ourselves, the lingerie industry could perhaps evolve into that sort of dimension as well. The sort of results that we achieved in the early 90s would be seen totally unacceptable as now. We used to put bits of flesh on the chest, or we used to put implants on. We say, well, that's good. And it was good for that era. But we've moved on now, and that would not be seen as acceptable. As far as the abdominal wall is concerned, when we started off doing this sort of reconstructive surgery, there were only one way of doing it, and that was actually to use the muscle, one of the 6 packs, and raise that muscle and put the implant and put the breast in place. That's the abdominal one. But now that has evolved from being a superior base tram flap to an inferior base tram flap to a free tram to a flap without any muscle at all, which is called a Dieppe flap. And now we're taking tissues from the gluteal area, and the techniques, the repertoire is increasing, and the finesse is increasing as it is. But staying with the measurements, as you can see on this side, the breast height A is 13 centimeters on the left, and is 18 centimeters. The breast B measurement, which is the one taken with the tape, is 18 on that side. So we got another 5 centimeters minimum to get from the abdomen. And then again, you can see the relativities of the lateral side as well. And that's a reconstruction with the abdominal wall tissue, and that's acceptable in the short term. This is a lady requesting a breast augmentation procedure, not phenomenal amount of breast tissue, but her nipple areal complex is 29 centimeters, and we're lifting that up to 22 centimeters. That's the result post-operatively. This is a lady with a chest wall deformity on the right side, as you can see, and that's causing her problems. And that can be dealt with by a combination of breast augmentation surgery and surgery to chest wall as well. The number of surgical techniques that are available now for breast augmentation include breast augmentation with round implants, teardrop implants, anatomical implants, as they're otherwise called, tissue expanders, fat injections, and have you heard of the Bravia system, where you put a prosthesis on the chest wall, and that expands, and then after that you can put autologous fat injections later on. And on top of that, there are issues with fat injections as well. And this lady's had surgery and also got a chest wall deformity. I just thought I'd show you the evolution of the breast implant manufacturers and the parallels that we could perhaps have here. This is a McGann style 410 implant, and these are anatomical. Of the implants that we have, we've got round implants, and the round implants are the ones that can give you that, as I said, the FHM look. The anatomical implants are the shaped implants. And once we've taken all the measurements, then we have a matrix to work on. And where it says FL, it means, you got FL means full height, low projection. Then you got full height, medium projection, full height, full projection, and full height, extra large projection. So relative to the breast base and the height, we've got different degrees of projection. And that's the wide range. So within this matrix, within this particular matrix, ignoring the extra height, there are 15 anatomical implants with low projection, 27 with moderate projection, and 36 with full projection. And this depends on the manufacturer would like us to put all this into a sort of computer program and then leave the decision making to the computer. But there's more to it than doing that. And it's an assessment of the whole patient's chest wall, and at least 5 or 6 measurements that we require to take. But that's the sort of detail that we're going in for breast augmentation surgery, which is evolved significantly, as I say, from the early 90s, where there was not a great deal of types of implants that were available. And as I said, if we wanted to go that extra bit larger, then we'd end up putting one implant in and then saying, well, we'll put another implant on top of that, which is a sort of double bubble effect. It actually doesn't look very nice. And I suspect still patients roaming around from that day having 2 sets of implants in. Not right, not appropriate. And then the other thing is, as I'm sure you've heard some celebrities who want to go that extra bit large, and I think the name of a celebrity was mentioned here already. We can get designer implants as well, fit exactly to the size of what the desire is. So coming to patients like it is not unusual for me to see in a week, in perspective, 2 to 3 patients referred for breast reduction surgery. That number is decreasing somewhat because GPs are not expected to refer that many, and that's another story altogether. And we're also creating guidelines based on BMI, but for a population base of about 250,000 in my NHS, 2 to 3 a week is actually a significant number. And if you look at the number of plastic surgeons there are in the UK, a significant number of people, as we speak, are being referred for breast reduction surgery. Obvious things such as neck, shoulder, and backache, intertrigo, fungal infections in the inframammary fold area, groove strap problems, and I've seen sad problems where the groove strap has created such a dent that you'd expect that once the bra has been taken off, that would fill up. It's a sort of temporary phenomenon, so to speak. But I've seen patients in whom you take the strap off and it doesn't matter. There has been fat atrophy. And the only way to actually deal with that is to consider a fat injection to that area. That's how bad the atrophy has been due to inappropriate bras and the problems that they're facing. We'll come to the last 2 points. I've got some photos to show my point as to the bra being at an inappropriate level to the inframammary fold. It's not necessarily some of these patients, and I keep on calling them patients, which is interesting. But when I'm seeing them, they are in my clinic. They're not my clients. They are my patients, at a level much lower than the inframammary fold. And again, the relatively bra underwire inflexibility from medial to lateral. And I think another problem we talked about breast body shape, and more women in my clinic I see whose breast bases, the bra, the width measurement B is going well into the axillary fold, and that can be a significant issue, because how are we actually going to measure these patients up properly for bras? And I think that's another issue. I've seen patients whose bras do not fit, but on the surface look okay, I guess. A patient who's come to my clinic, such bad problems with problems related to poor fitting and the inframammary and the digging in of the wire, that she's actually got a towel over there. And that's not a very nice phenomenon. She's got grade 2/3 ptosis of her breast, and as you can see, the bra's actually left marks on her. Yes, when the bras have especially not been marked up properly, there's a tendency to tip up with the underband riding up the back of the wearer. We find that. We also find, as has been alluded to, the compensation is with tight underbands, and that can lead to even more problems, such as problems with back and shoulder problems. And I find a lot of this, especially when the underwire bras, where there's a significant constriction. And this is a point, and this is relative in terms of a unidimensional measurement, and we've got to look at the whole perspective as well, because of the breast tissue going into the armpit as well. But the breast distribution varies relative to the inframammary fold at that particular point as the cup size and ptosis increases. And that's where came back to the issue of the breast being a complex organ to measure objectively. And these are sort of problems that you are facing and we face as well. And this is another lady come to my clinic, and I've taken some measurements. The definition of gigantomasty is generally where, when we do surgery, we take out 1.5 kilograms from each side. And she would generally come under that sort of area. The unfortunate thing is gigantomastia is a definition based on post-operative measurement rather than pre-op, and that's an interesting point. It would be so nice if we had facilities, and I wait to hear the talks from the 3D measurements as to how well can we assess volume and weight prior to surgery, because that's going to be very relative in the new NHS as to how much tissue can be taken out and should be taken out. So taking some measurement. The fascinating thing, as you can see, the breast height on both sides is 14 centimeters, but the distance with a tape, breast base B, is 31 centimeters. The distance from the upper part of the breast, where the breast is effectively onto the chest wall, to the inframammary fold is 31 centimeters. The breast base, on the other hand, is not that so much of an issue. 20 centimeters with calipers, but 26 centimeters with the tape. And the nipple areal complex suprasternal assistance are 34 centimeters. Grade 3 ptosis, as one can imagine. And you can see the sort of groove strap problems that she has as well. And in her case, the breast, as you can see, is going fairly well into the axilla. And this is to show you another measurement. If you recall, that 15 centimeter measurement is the distance from the upper part of the underwire to the other part of the underwire. So that 15 centimeters, bless it, has got to move up to 26 centimeters, and perhaps a bit too much of a tall order for that bit of underwire to do, from 15 centimeters. I know the underwire has a degree of flexibility, but from 15 to 26 is perhaps asking a bit too much from it. And this is a problem that we see, and to demonstrate this, you could see the slide of that woman who was wearing the towel underneath, and this is sort of problem, inadequate support of the lower portion of the breast, where the breasts are then sinking into the bra like that. And this is a measurement that I like to take in my clinic to demonstrate to patients that when they come to me and say, well, I've been to several shops and I've been measured by various organizations. They've all said I'm the right fit. But when I look at them and I can see, if you can see very closely, you can see the mark where the underwire is, and the distance from there to there, from the inframammary fold to that area, is about 7.5 centimeters in this patient, and that's a big difference. And that really can't be doing the job. And I've seen up to 9 centimeters as my personal record. But the problem is that you can send them back for bra measuring, and that distance may not necessarily improve. And there are many, many reasons why that happens, and that's why we're all here today. So we've talked about issues such as the underwire supporting the inframammary fold, but the rest of the breast bottoms out, but it's not necessarily supporting it all the time as well. The breast can get compressed and distorted in the fashions that I've demonstrated. The breast is pressed further against the torso, and this can leave potentially more problems with maceration, rubbing, and intertrigo, which is sort of fungal type infections. We've alluded to a bit of repetition here, but we're finding this more and more in our clinics, and doesn't need to have scientific evidence, as walking around in the supermarket can show. The basal metabolic index is increasing, as we go over the last few decades. Coming to current bra measuring, these are statistics that I was just driving past Nottingham Trent University on the way here, and I've got further statistics. The issue is, do these statistics really matter when the women are happy? And I think in general terms it is fair to say that at the sort of 36 B, C, perhaps D level, it perhaps doesn't matter. But when it comes to the groups of patients that we are dealing with, it does matter, and that's the gist of the latest Rich report and the problems that we're seeing. And this is an interesting bit of research done by a plastic surgery unit in Manchester. And they found that 99% women with large breasts wore the wrong size bra when they were referred for breast reduction surgery. And the one person who was not wearing the wrong size bra was actually not wearing a bra at all, and that's why it came up as 99% rather than 100%. So there is an issue. But as I say, all these things need to be seen in their context. And so what if 70% were wearing the wrong bra? It doesn't matter a great deal. It's not as if the government's going to set up an office to deal with these issues. They've got off gem and off what. Just think what they'll say to this industry. And again, this has been alluded to, and then the trigger for this meeting today. I think the key issues here is to reflect on why is it, firstly, the relevance, and I think for the standard fit, perhaps it's not that relevant. For the group of people I'm seeing who I instinctively call patients, because there are my patients, it is an issue. And is it because we're not measuring enough taking enough parameters into account, which would appear to be my view from a simplistic point of view, given the number of measurements we take. And I know it's easier for me to request a patient to take their clothes off and with a chaperone take all the measurements. And I know it's difficult in the setups where you work for that to happen, but it's unidimensional, and it's perhaps not taking account of the various parameters that need to be taken for the complex problems that we are seeing for the Plast group of clients, really. It's a measurement of volume, the level of the chest, the breast, the measurement was taken. No account is taken, as in the measurements that we are taking, of breast size, shape, or droop. Again, no account is made formally of breast height and width, and definitely not even simple measurements, such as the tape measure, the breast base B, breast height B. I know it may be difficult to put calipers, through the bra or whatever, but at least some sort of assessment of that can be perhaps considered. And then we talked about BMI and obesity. We talked about breast hypertrophy, fashion again, and bra fitting practices. And right, this is again, we've talked about what can be done in terms of the evolving practices. Aesthetic surgery on the NHS. When I started plastic surgery in the early 80s, anybody who requested cosmetic surgery, we actually used to put on the list. The waiting lists were about 5-6 years, but they were put on the list. And by the time they were called for, most of the problems had gone away or they'd had it done. As you are aware, the NHS has evolved, and waiting times came down to about 2 years, and now they're 18 weeks from referral to surgery. So in an attempt to get some rationalization and rationing, there are guidelines on the guidelines for aesthetic surgery in the NHS that we are expected to follow. And when we started off with these guidelines, we could do breast reduction on patients with a BMI of 30. Then currently it's 27, but I wouldn't be surprised if it came down to 25. And if that happened, then not many people would be referred to us, because it's quite difficult to come down to a BMI of 25, myself included. In the national guidelines for aesthetic surgery, I'm not sure whether this group is aware of this, but all PCTs, primary care trusts in the UK, from April 2005 were supposed to get advice on bra fitting and support bras for patients referred for breast reduction and asymmetry prior to referral to surgery. Now, I tried to establish this within our region, but it's actually very difficult because, in a sense, when all the statistics are showing that bra measuring is not an exact science and it's not that helpful, then how can we scientifically ask for this to happen? And there's a bit of inertia. If there is scientific, if we can work together to develop proper bra measuring and deal with some of the issues that some of these patients have when they come to our clinics, that would be great. And I think that's something that we can always all work to. And there is this interlink that is set up for us already that we can work together as a team. It's interesting that sometimes the fashion industry, when patients come to me requesting breast augmentation surgery, and they try to put me on the spot and say, so with this particular breast implant, what sort of size am I going to be? To which I can then take a step back and say, well, you may be measured up wrongly today, so after the operation there's a higher chance you'll be measured wrongly because you're going to be larger than what you are. So statistically, I cannot give you any guarantee as to what exact cup size you're going to be. Wouldn't it nice if I could guarantee cup size if we had more extensive and more helpful measurements in that sense? I don't think that this question will be asked of any of the leaders at the election debate, whether they will be required, but with rationing on the cards, it is more than likely that all sorts of aesthetic surgery will be reduced. Breast reduction surgery, I would not be surprised if it is very much taken off the menu. And as an organizations, we could perhaps work towards, helping these patients who do have significant problems with bra fitting. I accept that a lot of them, once they come for surgery, they actually want the surgery. And you look at them and you say, some of them are so large, especially the two patients you saw. They're not, bra fitting may not help them as much. But there's an intermediate group of patients who I see who actually, if they did get good advice, may not actually go ahead for surgery. And I think that's an important group, that if you can work towards help, and that in my view, would be brilliant. So, we have evolved. I mean, I've seen, my own specialty evolve, since the late 80s, early 90s. The techniques available, the repertoire that we have, and always constantly developing things further. Can we gain from our shared and evolving experiences? Can the surgical breast measurements that we take help better bra fit and help us look beyond bra size, cup size? And I know the 3D measurement areas is another exciting area as well. And I think this is another issue, the assumption that was made by today about a 50%, not getting it sort of right level. And I think this is a different paradigm here in terms of, what I showed you about the implants and the wide range of implants. Can we empower women to decide what they want? Degree of support and uplift relative to their breast shape and size. And let me show you the marketing for breast implants. As an individual as you are, everybody is different, which is why we've created our unique matrix of height and projection ratios designed to complement patients' height, weight, and body shape. You can choose from 9 different cells in low, moderate, and full height, and projection options with a variety of base bets. All of this choice means you can meet patients' expectations with greater confidence. Is that the sort of model we should be looking at? I think I've kept to time. Thank you very much. I'm usually more used to speaking to plastic surgeons. I don't think I've ever spoke to such an audience of attractive women. So thank you very much for the opportunity.